At the Nocturnists, we are careful to ensure that all stories comply with healthcare privacy laws. Details may have been changed to ensure patient confidentiality. All views expressed are those of the person speaking and not their employer.
This episode of The Nocturnists was made possible with the support of the California Medical Association. This is The Nocturnists, stories from the world of medicine. I'm Emily Silverman. Tina Munjal is comfortable outside of her comfort zone. She became a surgeon despite not fitting the stereotype of a surgeon. She became an otolaryngologist despite how hard it is to say that word. She recently went back to school to do a postdoc in computational neuroscience despite having no computational background whatsoever. And she told this personal story to a big audience of strangers, which we'll hear in a minute. After the story, Tina and I will talk about the perils of getting too good at one's job.
I feel that once something is second nature, it becomes easier to tell ourselves that we're done.
But first, here's Tina.
It was 9 p.m. on a Tuesday, one of my first overnight calls as a newly minted otolaryngology or ENT resident. I got a frantic call from one of my attendings. Tina, how comfortable do you feel packing a nose? Packing a nose is the ENT term for stopping a nosebleed, or more officially, epistaxis. Epistaxis comes from ancient Greek, roughly translates to drip from above. Actually, epistaxis can range from a drip to a fire hose. And that fire hose can be life-threatening if not turned off quickly. Unfortunately, to that point, my only exposure to epistaxis had been in the form of a practice dummy, where the stakes were just as high as getting red food coloring on my clothes. So how comfortable did I feel packing a nose? I feel okay, I said back as confidently as I could. Good, because Dr. Jones is on his way in to the emergency department with a really bad bleed. Whoa, okay. Dr. Jones was not only a physician, but a powerful physician who occupied a seat at the table in very high places at the hospital where I worked. I need you to do a good job, Tina. I'm counting on you. Great, okay. So I knew the different pathways the situation could take in theory. For a little dribble, I could squirt a generous amount of Afrin and hold pressure on the nostrils. For a little worse bleeding, there were medicated powders, gels, and absorbable packing. If it were truly bad, I could go for something similar to a tampon, and if all else failed, a Foley catheter designed for the bladder up the nasopharynx. Based on the description over the phone, I decided I'd start with something called a Rhino Rocket. It's an inflatable balloon that exerts pressure on the bleeding vessel and also has a coating that facilitates platelet aggregation. Sounds great on paper, but I had never used it. Time was ticking. Dr. Jones was going to get here any minute, so I had no choice but to consult the ultimate authoritative source, YouTube. YouTube is the modern savior of junior surgical residents everywhere. Okay. Based on this very legit-looking video, I was gonna need to soak the balloon in sterile water for 30 seconds, aim for the floor of the nose rather than the brain, which is a known possible complication if this procedure is performed incorrectly, inflate the balloon with the patient awake, of course, and hope that this was sufficient to stop the bleeding. So how did I, the kid in school that would glue her hands together instead of the paper during arts and crafts, get here? Medicine versus surgery is often the first question that medical students ask of themselves when deciding a specialty to pursue. This dichotomy comes down to thinking versus doing, brain versus hands, ambiguity versus concreteness. But to me, these opposites felt completely wrong. Otolaryngology is a specialty of the senses: hearing, speech, taste, smell. It is a surgical specialty, yes, but it's so much more than that. It's a specialty that can restore hearing to the deaf. But is it surgical to help a patient reconcile between improved speech discrimination for severely impaired music listening when deciding to get a cochlear implant? It's a specialty that takes care of professional singers and voice actors. But is it surgical to talk to a patient about a new diagnosis of laryngeal cancer when she depends on her voice for her livelihood and her identity? Not sure if it's surgical per se, but these processes are thoughtful, emotional, and ambiguous. For me, it was never about being a surgeon and then incidentally choosing the head and neck. I chose the head and neck first. Being a surgeon was just par for the course. But these are lofty ideas. Day one of my general surgery rotation as a medical student, I got a very rude awakening. We had a two-handed knot tying assessment and were timed and ranked in comparison to our peers. I came in dead last. Every move was ultra-conscious. Left hand turns inward by pronation. Thumb swings under to form first loop. Left strand crossed over right strand. You get the idea. Okay. The next day was my first real day in the OR as a student. I did the med student dance that you guys might be familiar with, right? Trying not to break the sterile field, trying not to get in the way, nodding emphatically when the attending asks if you can see what he's doing, right? All you see is the back of the scrub tech's head. I did that for 18 brutal hours. And then the attending asked me to throw in some buried deep dermals. I had never even heard of the term before, so I asked him to walk me through it. His response was, I want to train people who can look at what I'm doing and just do it. I don't want to have to tell you. Thank goodness for surgical masks. I held back tears and started considering the possibility that my dreams were not enough. Later in the rotation, we had a session on surgical learning, and we're introduced to this concept of the 4 stages of competence. First, there's unconscious incompetence. You're terrible, and you don't even know how terrible you really are. Next, there's conscious incompetence. Now you know you suck. Third, conscious competence. You finally kind of know how to do something, but it takes immense concentration. And fourth, unconscious competence. The skill is second nature, like driving someplace and not remembering how you even got there. That's the very definition of a comfort zone. That was a huge lipo moment for me, honestly, because as a third-year med student, I basically always sucked, or at best, sucked a little less. And yet, I compared myself to this standard of effortless expertise, berating myself that I wasn't already there. By the end of the rotation, after immense deliberate practice, I went from being dead last in the knot tying assessment to being amongst the fastest in my cohort. On the very last day, the chief said to me, "You get surgery. I hope you choose this specialty." And so I did. I chose otolaryngology, head and neck surgery, and it chose me back. Since starting residency, the obstacles have taken on a somewhat different face. I look a little different, for example. I'm the only woman in my class, absolutely no women in the class above me. I happen also to be a woman of color with kind of a baby face. I've had nurses of both genders address my tall male medical students instead of me to get report. I've had patients question my ability to perform their procedure without knowing anything about me except how I look and at most my name. Shouldn't you be in school, young lady? Where's my doctor? Surprise, it's me. Yeah. I still have those nights where I go home and wonder, am I even doing this right? Early in residency, I was given the feedback that I needed to be more efficient on the surgical ward so that I could spend more time in the operating room. Flash forward some time from that feedback. I was rounding in the room of a patient. As a junior-most person on the team, it was my job to tend to the patient's surgical wounds. The seniors took a quick history and physical, congratulated this patient that it was his last day in the hospital after a several-month-long, excruciatingly difficult admission. They then left the room, went to the neighbor's room, leaving me to finish up. As I was wrapping his wounds for what was supposed to be the last time in the hospital for this gentleman, my eyes were drawn to the monitor on the wall. His oxygen saturation was drifting slowly down. No alarm was going off, just a steady flashing blue light, 88%. An hour later, the stat chest CT showed multiple massive pulmonary emboli, or clots in the lungs. If he had been discharged that day, he could have died at home. In other words, if I had been more efficient, he could have died at home. Back in the emergency department, Dr. Jones rolls in on a gurney, accompanied by his wife. He's holding a blood-soaked wad of tissues to his face. There's a saying in medicine, see one, do one, teach one. But nobody talks about the quantum leap between seeing and doing. You never want to admit, this is that one I'm about to do. I take the wad of tissues off his face, and sure enough, there's a steady, pulsatile stream of bright red blood coming from the left nostril. He's pale, his heart is racing, and there's a huge clot in his throat, confirming he's lost a lot of blood already. I walk him through the plan, partly for my own sake, and follow the steps from memory. 1, soak balloon. 2, follow the floor. 3, inflate balloon. 4, pray. And so we waited. 10 minutes later, there's no more blood. 30 minutes later, still nothing. Not sure who was more surprised in that moment, the patient/doctor or me. I admitted him for overnight observation, and the next day he had surgery to definitively ligate the offending artery. Since then, I've packed dozens of noses, but there's a first for everything, and that was quite the first. Where we stand in the stages of competence as trainees, where we should stand, and maybe most important of all, where we think we should stand. These are not objective facts. I know now I linger longer in the conscious struggle. If I could, I would add another stage of competence between steps 3 and 4. It's called just outside the comfort zone. Comfort, if obtained too early, leads to complacency. Don't get me wrong, I want to be really good at what I do, just not take it for granted. I want to use humility to my advantage, to remind myself there's always more to learn. There are always ways to do better. And so for now, I think I'd rather stay just outside the comfort zone. I might be a better surgeon that way.
I am sitting here with Tina Munjal. Thanks so much for coming in.
Thank you so much for having me.
I think this is probably the shortest duration between story told and interview had. Usually there's like months that fly between the performance and the interview, but you just performed last week.
I did. It was like 4 days ago. It's so exciting to be here.
So maybe I'll just open up then on that note. How was the experience for you performing the story?
It was incredible. I think it was one of the most fun things I've ever done. I had done a little bit of storytelling before, but this was definitely the biggest crowd, and I think it was also definitely the most sort of intimate look for myself even at who I am and where my life is going. Yeah.
So we'll get into that a little bit today, if that's all right.
Yeah.
But I want to start with your specialty, because we have never had anyone from your specialty perform at our show before. So I was so excited to have you. And I just wanted to say this word, Otolaryngology.
You got it. That's right.
Tell our listeners, what is Otolaryngology?
Yeah, so Otolaryngology or otolaryngology or head and neck surgery or ear, nose, throat, ENT, they're all the same umbrella specialty. Basically, it's the surgery and medical care, actually, of anything in the head and neck, even parts of the brain. So one of the common sayings that we like to say is from dura to pleura. So the encasement of the brain all the way to the encasement of the lungs. Yeah.
In your story, you describe this patient who comes in with a nosebleed and you're getting ready to shoot something up his nose called a Rhino Rocket to stop the bleeding. And you say you want to angle it in the right direction so not to shoot it up and into the brain.
Right.
And that really brought me back to my ENT rotation in medical school, because I remember one of the attendings talking about how in order to go to ENT, you really have to have an excellent visual spatial ability, because the neck and the skull, everything is kind of packed in together, and you have the sinuses and you have the vestibular labyrinths, which are these like loops of fluid that stick in different directions. It's like not, I imagine in a city, like instead of the city being a grid like Manhattan, it's just all of these angles and all of these different things. Can you talk a little bit about that? Is that a huge challenge?
It is. I think actually you really hit the nail on the head with why my specialty is so different and so challenging and so beautiful at the same time. I think that intricacy is actually what draws a lot of people to this specialty. It's sort of like in London, the taxi drivers have to like memorize the roads. It's kind of like that. You have to internalize the map. And also be aware, just like a taxi driver almost, like where there might be blockages, where there's going to be traffic, where there's going to be those idiosyncrasies to a specific person, to a specific neighborhood, let's say.
And the structures are small when you think of the surgery on the vocal cords that you mentioned in your story, or doing operations on a structure as small as the cochlea, which is the inner ear, that spiral-shaped, fluid-filled sac. Do you have to do them all like under a big magnifying glass, or how do you manipulate those delicate structures?
Yeah, that's a really good question. A lot of our surgeries are actually microsurgery. So we will use either a microscope or endoscopes, which are sort of these small telescopes that can be fit into small areas. So in the nose and even in the ear, we use these tiny telescopes. And then also there's something called loops, which are ultra magnified glasses that can help you visualize small structures. But actually early in training, depending on the preference of the attending and the subspecialty that you're working in, we're actually encouraged to not use loops sometimes when we're first starting out, so that we can actually learn the map on a more big picture level. So like sometimes when you're driving someplace, you actually can change the setting in Google Maps or Apple Maps, for example, where you can take a big, zoom out and look at the trajectory of where you're going. Because if you're just looking at the arrow of the compass, you might not really know, okay, but where am I supposed to turn in a mile? Do I stay in the right lane? Do I stay in the left lane? So when you're wearing loops or when you're looking under the microscope, it's sort of having that arrow pointing where all you see is that tiny field. So sometimes as junior trainees, we're encouraged to take the loops off, look at what the entire scene is showing you so that you can anticipate where we're trying to go.
You also talk about head and neck being the specialty of the senses. And I love that so much. And I told you a little bit backstage and also a little bit this morning about how I've been having ringing in my ear, and I had it worked up, and I'm still not really sure what's causing it, but I had never had a symptom like that before, where it's just I'm hearing a sound that isn't there. And it's very weird. It's different than having back pain or, a UTI or something. It feels somehow more, I don't know, maybe you can articulate it better than I can, but what is it that's so special about working with the senses?
Yeah, so tinnitus, what you're describing, is probably one of the strangest, most challenging pathologies, and also most annoying pathologies that we work with. I have tinnitus as well, as you and I talked about. So the senses, the way I envision them, it's sort of the way that we interface with the world and how we interface with other people. The brain is often admired as the source of personality, the source of love, the source of emotion. But, if your brain cannot make a connection with the person in front of you, you cannot express those emotions that you might be feeling. So in some ways, if you don't have the senses, you're sort of restricted to yourself. And so I envision the senses as a way in which we can experience the world in its complexity.
You joke in your story about being a petite woman of color with a bit of a baby face and how that has been an obstacle for you in medicine. And I'll just add that when I was in medical school, I was really interested in surgery at the beginning because I loved watching Grey's Anatomy and I thought it was so sexy and so glamorous and also just, fascinating for all of the reasons we just described. But I was really turned off by the culture that I encountered and how just masculine it was, for lack of a better term, and I didn't feel welcome. And anyway, just wondering if you could share a little bit about your experience with that.
Yeah, there's a saying that you should only choose surgery if you can't see yourself doing anything else. I can see where that phrase comes from because it is a very demanding field that requires a lot of personal sacrifice. But at the same time, I also really hate that phrase because what you see yourself doing is based on a stereotype of an area that you may not really know much about, and it's also based on a stereotype of yourself. So the narrative that physicians and the general public have told for decades about surgeons is that they're powerful, athletic men. And so the narrative I've told myself about myself is that I'm kind of a bookworm, and I never really played sports growing up. I would much rather read a book on the couch than anything else, really. And so if I apply that phrase, can I do surgery because I can't imagine myself doing anything else, it just doesn't even equate. Putting that aside, I think there's so much value to being different, actually, in a field where I approach things differently than my peers in many ways. Because if you think about it, disruption, whether it's in technology or healthcare or anything, disruption comes from thinking differently. And I think if we perpetuate the narrative that you must be the same type of person to enter any kind of field, then we are basically disabling the opportunity for progress and for disruption in meaningful ways.
So in your story, you give us the 4 stages of unconscious incompetence, conscious incompetence, conscious competence, and unconscious competence. I hope I got that right. But you argue that there should be an additional stage in there. Can you expand on that a little bit for our listeners? What would that look like?
Yeah, this stage between 3 and 4, so between conscious competence, where you know how to do something, it just takes a lot of effort, and between unconscious competence, where something is second nature to you. I argue in my story that there should be another identified stage between those two that's called just outside the comfort zone. And that's kind of the space that I try to occupy, or I aim to occupy, with any new skill, any new idea. And that's because I feel that once something is second nature, it becomes easier to tell ourselves that we're done. We're done developing, we're done improving. But if we stay just outside of that comfort zone, then I think there's more opportunity for self-reflection and for growth. So, for example, I referred to in the story an example of unconscious competence as being like driving somewhere and not remembering how you got there. So on the one hand, you could see why that would be helpful, because then your brain can focus on other things, right? You can listen to a podcast. You can talk to your family on a hands-free phone. You can admire the sights around you. So there's a benefit to that. But at the same time, it's kind of dangerous to be like, oh yeah, I don't need to pay attention anymore. I can just make it from this, point A to point B in the city and not even worry about it. I can accomplish so much in that time, which is true. But what if there is a change in the road that day? What if there's a pedestrian that, is crossing the street in a place where they shouldn't be? Or even something more beautiful than that. What if there's a really cool new thing happening in the city, or a cool new restaurant on your way home? If you're so dispersed because you're so comfortable, you're not going to notice the challenges, you're not going to notice the beauty. And so I argue that we should maintain a sort of an intermediate consciousness, even once we start improving, even once we start getting really close to being good at something, because it's only once we're in that limbo that you can start appreciating the world around you and start appreciating your own progress.
Tina Munjal, thank you so much for coming in to chat. It's been a pleasure.
Thank you so much for having me. It was an honor to do this.
Thanks so much for listening to The Nocturnists. We'd love to learn more about who you are, so we've set up a special voicemail for our audience. Leave us a message at 415-991-0958 and tell us why you're listening. Your voice might even be featured on a future episode. This show started as a passion project, and we're able to continue our work through the support of you, our audience. So if you like what you hear, please go to our website at thenocturnists.com and click donate. And if you or your organization are interested in supporting our podcast through sponsorship or having our team produce a show in your town or at your institution, please get in touch. The Nocturnists is made possible by the California Medical Association, an organization that's done so much great work with medical student loan forgiveness, supporting primary care residency programs, and really keeping the doctor-patient relationship at the center of medicine. Learn more about them in the show notes. I want to thank our executive producer, Ali Block, our head of story development, Adelaide Papazolo, our podcast producer, Liza Veal, sound engineer, Alberto Hernandez, and our communications director, Chloe Lassard. Our original artwork is by Lindsay Mound, and our original theme song is by Yosef Monroe. All other music is from Blue Dot Sessions. Please subscribe, rate, and review our show on Apple Podcasts. It really helps other people find us. And of course, spread the word to your friends, family, colleagues, maybe even your own doctor, or whoever else you think might enjoy these stories and conversations. Until next week, we are the Nocturnists.